Welcome to the Training Stimulus podcast. Today's episode: is osteopathy a waste of time? Yes, this is a clickbaity and potentially triggering title, but it's also a genuine and sincere question. And we have a very special guest to help us answer it, Mr. Lewis Ferns. So as a bit of background, I met Lewis 4 or 5 years ago when he attended one of my workshops. Since then, he's been through all the Training Stimulus education, the mentorship, the alumni program, and we continued with some mentoring beyond that even. And he now does some work for the Training Stimulus, helping us with the mentorship program. And it's been an absolute privilege and a pleasure watching his career develop. He's doing some phenomenal things, getting amazing results for his clients. And one of the reasons why we're talking about this question today is that even though he is a qualified osteopath, so he was a master's student when we met at that workshop and has been practicing osteopathy for a few years since. But despite being a qualified osteopath, he has all but dropped osteopathy in favor of using movement mechanics for his clients and patients because he thought it was more effective. So we discuss osteopathy, but I think this discussion can extend to other practices as well in principle, and we'll get into the detail. So hopefully this resonates with a lot of other practitioners out there. And if you are an athlete or a coach and you work with injured people, or some of your people might get injured, hopefully this helps to contextualize who you should send your clients or athletes to when they have an injury and how to think about injuries from a broader perspective, and gives you some ideas of how the traditional education system works and its pros and cons. This is one of the reasons why I like podcasts, is that we can get into the nuance and it's not just a wholesale broad brush statement saying that osteopathy is a pile of shit, which it clearly isn't, but we can discuss the pros and cons of it and other methodologies. So hope you find this episode really useful. I really enjoyed the chat and tapping into Lewis's expertise. If you want to discuss this further, please do drop a comment if you're watching on YouTube, or if you are listening, please get in touch with us at _training_stimulus or at ashgrossman.coach, and you can find Lewis on at lewisferns.coach. But yeah, hope you enjoy this episode, guys. Let's get into it. So, Lewis, is osteopathy a waste of time is the question we're going to discuss today.
Yeah.
And I know it's something we've talked about a lot in the past: osteopathy, physiotherapy, chiropractic, various different manual therapy treatments.
Mm-hmm.
And I think we've had some common experiences and maybe frustrating journeys through traditional treatments. But you're obviously an osteopath yourself, qualified and practicing. So have a very expert opinion on the topic.
Yeah.
So let's start with, could you give us an overview of what osteopathy is?
Yeah. So osteopathy, most easily put, I would say is a mixture of techniques and a belief that, so the founding father, he always believed that, and it's something I like, is that you allow the body to heal with your guidance, essentially. Like, the body has self-healing capacities and you almost need to guide it through that. And that's very paraphrased, and that's something I believed. I was which is quite nice. And they kind of, for better for worse, in some cases quite anti-medicine.
Yeah.
And then that's why I don't think it's been accepted very well inside of medicine, and it's coming to the NHS now, but that's another story. But what is osteopathy? I would say it's a way of assessing and treating someone manually.
Okay.
And they use a mixture of techniques, and there's different aspects of osteopathy, and I think that's what I struggled with, where I am very structural, mechanical by nature, just because of what I've experienced successfully with my own injuries. But I suppose I'm going off on a tangent, but when I was injured, the osteopath I saw was the best out of the bunch, essentially. So that's why I decided to study it. I feel like I've gone off a tangent though.
No, that's good. That's a good answer. And while we're on it, like, what was it about the osteopath that you saw that distinguished them?
Yeah, it's quite simple, really. So I was seeing the NHS physio, and I had herniated disc, 2 discs for people who don't know, and I was seeing an NHS physio for 3 to 6 months. I think it was more towards 6 months, and they was doing a basic Mackenzie method with me, which is essentially laid on your front, hyperextending your back, and I was just laid on my front all the time because that's the only position which felt good because I was essentially extended and not flexed. But that was pretty much it. I'd go in, I'd show her that I've been doing it, and then it's like 15-minute appointments once a week for 3 months, and then they would put me on a traction machine where they would attach me to like a weightlifting belt on a machine, and then do was like pull my spine apart, which felt pretty good when I walked after, because every time I would stride, that would lengthen my sciatic nerve and I get like a ping. So after I had some traction, I'd have like short-term relief for a few hours. But I had this super intense groin pain, and it was muscle guarding essentially. And I saw a chiropractor, and he manipulated me, but didn't really address the groin. And then the osteopath was the first person who actually explained to me that well, that's just where your psoas is inserting, and you've got muscle guarding around your back because where the psoas attaches to your spine, and give me a bit of a release, and I felt a lot better. And I was like, oh, he hasn't just looked at my back. It was the rest of the practitioners are very localized, and I was like, he's actually looked at something else, which is my back, and he's given me a little bit of relief. I was like, that's pretty cool. So I was like, oh, maybe I could do this. I had like a little inkling, because at the time I was a scaffolder. So it was, and I left school at 16, so I wasn't in the mindset of changing career. Well, I was then, because my body was pretty ruined.
Yeah. Okay. So we'll do your life story in another episode. I do want to do that one. But when you decided you were going to learn osteopathy, what was the student experience like? Like, what sort of approaches, techniques, principles did you learn?
Yeah. So first year is very basic anatomy, like origin insertions, learning soft tissue techniques, and basic assessment of active and passive, getting them to do it, and then you moving them through the same range of motion of flexion or pronation, supination of the elbow. And you go into valgus and various stress tests in year 2. But very basic anatomy, some physiology, soft tissue techniques. That's first year. And to be fair, it's not hard. It's just a lot of volume of new words, just things to learn, which is different. Going into second year, if I recall correctly, that's when you start to have a little bit of time with patients in clinic, and you start doing a little bit more testing and a little bit more hands-on. To then you have to pass certain tests in clinic. To then third year you're having your own patients. The fourth year then you're essentially you've learned everything you're going to learn within the university curriculum. A little bit of HVT manipulation based stuff, but then you're writing your dissertation. So
what's HVT?
High velocity technique. So it's just taking a joint through a small range very fast to try and get a cavitation, which is just a pop of the joint to increase range of motion or desensitize the surrounding areas.
That was going to be my next question, because I think you must get this question all the time of what does it mean when a joint cracks or pops, and how do you answer that, and in what situations do you use that?
I rarely use it. Oh, what was the first question?
How do you answer the question? What does it mean when I crack my fingers or crack my knee?
Yeah, it's just the way I just explain it. It's that audible sound is just gas leaving a joint space. And when do I use and people through experience, they've maybe cracked the back on the chair as a kid or used a foam roller, feels quite relieving, quite nice. But you will rarely get the click or the audible sound from the segment which is actually restricted. So people who click the neck a lot. They feel like they need to, but what ends up happening is the ones they can mobilize just end up becoming hypermobile, and the one that they actually need to mobilize just stays stiff, and everything just keeps getting looser and looser and looser. So people feel like they need to do it, or it feels very relieving. Whether that's part psychological or actual physical, I think people like to feel that sensation, similar to when we was talking about people like to have a sports massage because like they feel the pain, so like, oh, it must be working, but it's not really working because most people, say like a chiropractor, no offense to anyone who's listening, but if you probably listen to this, you're probably not a traditional chiropractor anyway. If you're needing 3 sessions a week every week for 3 months, then it's obviously not working. Yeah.
I think that's a lot of these techniques, you can boil them down to say they're not doing what you think they're doing, and not having the effect that you think they're having.
Yeah.
Which we'll get onto more later. So that's a great summary of the sorts of things you learn while studying osteopathy. So once you're qualified and you've got all these skills, how does a typical osteopathic treatment look if you're going by the book, doing exactly what you've been taught at uni?
Yeah, actually just caveat up quick on the HVT stuff. When do I use them? I forgot, I didn't mention that. And that's when someone will have like a facet irritation or lock, and if it is locked up and you do that technique, it is like highly effective, and that's sometimes all they need. But yeah, what does a traditional? Yeah, it depends on which type of osteopathy you've started to do. So, some guys were heavily into like visceral, like manipulating organs, and they would see a certain type of client, so their assessment would be different. But what I would do, or what I was more interested in, was considered as structural osteopathy. So with that, it's quite a comprehensive questioning of like what they're complaining of, and then actually going into like previous injury history, but a lot about stress, and it was quite all encompassing. If you wasn't skilled at that, sometimes that would take so long that the first session would almost be like a consultation if they're very complicated, because you'd run out of time. So it's like 30 or 45-minute sessions. But after that, it's like active, passive exam, orthopedic tests, and then from that information, you would have a diagnosis in your head, which then would influence how you're going to treat this person, which is usually hands-on, a lot of hands-on.
Can you just bring it to life a little bit more with maybe an example? Think of a specific client, so you don't have to name them, but they came in, and what tests did you do? What did that mean? And then how did you go about treating them? Like just a completely bog standard bread and butter.
Yeah. For me personally, or someone who just...
For you personally. So.
Now?
No, not yet.
Yeah. I think that's hard because I started doing the mentorship in fourth year. So I was already kind of influenced by your style. So I was already implementing that in university. So I was already like assessing squats, lunges in the active exam, where most people would just be like, the active exam for someone for a knee, for instance, they'd be sat on the bed, they would extend, and they would do, and then they wouldn't actually do flexion, but they would have like put the hands on the tibial tuberosity and get internal rotation of that would be it. But if someone had knee pain during a squat, they wouldn't actually assess the squat. So but yeah, say I would say like traditional osteopathy, like so they would, stand an exam, like look at them front, back and side, like see what their posture's like. Then say that the knee was sore, like active and passive knee exam, so get them to do it on the side of the bed, then physically move their leg. Then it's like soft tissue palpation along the joint line, see if like the meniscus is tear or if any of the ligaments are sore on either side. Maybe do some stress tests, and then go into like, I think it's like your patella tendon that's sore, and then they would like potentially like look at the foot and ankle or the hip, and then like maybe like, your midfoot seems a bit stiff, like physically try and like mobilize it, maybe it's like some soft tissue to the quads, mobilize the hips, hip flexors, and then that'd be like kind of it, I suppose.
Yeah.
Especially leaving from uni, I would say that's like probably pretty bog standard.
I think that's pretty good in terms of at least they look a little bit further afield than the knee.
Yeah, they try and teach that. They tell you to do that, but they don't really teach it. They're like, you need to look at the whole system. The founding fathers is like what's the quote about the whole body is more than the sum of its parts? Do you know? I can't.
That's good to me.
Yeah. So they know that the principles are there, but how they taught it, the curriculum is just swayed and it's not all that encompassing.
Okay. And cool. So you're qualified and you said you already started thinking about things differently as you're going through uni. I guess, when did you start to doubt the efficacy of the osteopathic approach or question some of the ideas?
Pretty early on, and I think because I had treatment from fourth year students, because they encourage you to like go to clinic if you got like an injury or a pain, like, oh yeah, book yourself into clinic and then you get treatment off like a fourth year. And I was like, won't mention him, he never made it through anyway, but he was bad, so bad. And I was just like, oh no.
Why was he bad? Like, what was it about?
He was very nervous, and he was like standing assessment, and he had like this like pair of curtains, you know what I mean? And he was like hand was shaking looking at me, and he was like, and I was like doing the like standing assessment, like and he was the practitioner, but you have two other students shadowing as well, so it's quite intimidating, to be fair. And I was, especially for someone who's like general population, general public coming in, they've had like three people staring at them and they're undressed, and he was just super nervous, and then just spent so much time questioning, got no treatment, but when he did treat me, it was terrible, and it was really, really bad. So I was like, so I saw someone else and they were okay, but the standard was quite low, maybe just for that year. There were some good people, as there always is. And then I also had a meniscus issue myself, and I went to clinic, and then and it wasn't getting better, and then they had the tutor come in. The tutor didn't really know what was going on with my knee either, and I saw a few people, and then I had an x-ray because it was getting worse, so it was like to get the next step for an MRI, and I was like, no one. You go to university thinking that your professors and lecturers are going to be really inspiring, and they weren't that inspiring, not for me anyway. And they couldn't deal with what I had, or they couldn't give me guidance and direction. And that's when I saw Gemma, originally in Gloucestershire, I think, somewhere around there. And that's when she took a real movement mechanics based approach. And it was just very like, oh yeah, because you're doing this, and this is why this area is getting overloaded. And I was like, oh wow, there is actually a system out there which gives answers, because everyone knows it depends. But can you give me a depends and, a little bit more?
Yeah. Shout out Gemma.
Yeah.
Smashing it. Okay, so even when you're at uni, you're starting to think maybe there's more to this and we need to look further afield.
Mm-hmm.
How did you explore, like, having had a great treatment or training with Gemma?
Yeah.
What steps did you take then to investigate slightly alternative routes than osteopathy?
Yeah, so I actually originally approached you for coaching. Do you remember that? Yeah. And you told me your price, it was too expensive. And you said, why do you want to get coached off me? And I actually remember saying, I was like, I actually wanted to learn from you. And even when I answered the question, I was like, maybe I don't actually want coaching. I just actually want to know what you know. But I was since had success with a movement biomechanics approach for my knee. I was very interested, and I was kind of then trying to find out, how do I learn about this? And I think I was in third or fourth year at university, and that's when I came across yourself. And I liked the way you broke things down and the way you articulated things, and I was like, I'd like to learn from this guy.
Awesome. Yeah, I remember you and Ben came to the
Stevens.
workshop.
Yeah.
I remember that.
Yeah. And I approached you then, I think. I was like, oh, are you doing a mentorship? And you was like, I've just started.
Yeah.
And I don't know if I was in the, like...
I think you're in the 3rd or 4th cohort.
Oh, really?
Yeah, but they'd been in person, a couple of in person before that, and then 1 or 2 online ones for your group.
Yeah.
Yeah, very early days. But cool. So I guess what was your train of thought? So you had joy with the knee with Gemma, and what was different about that compared to the struggles with the osteopaths you were dealing with at uni?
Yeah. I don't think sometimes it was just the osteopaths at uni. I think they were held back by the curriculum and the restrictions of how the university wants to teach the degree, but they couldn't give their tips and tricks. And there's not much evidence behind this, but I found it really helpful with this type of person when they're struggling with this. There was none of that because they wanted to stick within the guidelines of what the university is trying to push, because they're trying to get osteopathy recognised by the allied healthcare professions, which it is now. So it's in the NHS and it's seen as a legitimate career, whereas chiropractic, sports therapy, they're not recognised. So there was a big push for that to be evidence based.
That's crazy, isn't it? When you think about that, take a step back from it, the teachers, professors are not including stuff that they think works because they're trying to favour evidence-based stuff that they think is less effective, because doing so gets you signed off by the NHS or insurance companies and recognised as more credible.
Yeah.
By deliberately choosing less effective approaches.
100%.
Isn't that mental?
Yeah. And that's why mentorships are so effective, because the person who's designed it has put everything they know what's effective into digestible, actionable steps. So you practice in 10 years, you get all that information distilled, and they're trying to give as much value as they can. The amount of value that's given at university is very low.
Yeah, I think the other thing that is challenging with the university setup is just the speed of updating the syllabus. Because the syllabus has been fixed for a long period of time, for somebody to change it, to cut something out, to add something in, it's going to take a lot more approval, and you're going to probably get a few people need to sign it off. And you contrast that to less formal education, like a mentorship. As soon as you learn something, as soon as you know it's good, you're able to pass that on to the mentees.
Yeah.
And I think that's why we're seeing so many people take non-traditional education pathways.
Yeah.
Because the speed of updating information is just as fast as it gets, really.
Yeah.
And I don't know how universities are going to compete with that, because if you're still teaching information from 50 years ago that a lot of people know is a bit dusty and outdated, and a big percentage of that information isn't even going to be applicable to you, I think that's the frustrating thing for most people at university. You're learning stuff and you're learning it to pass the exam. Like, I'm not going to apply this when I go out into my job. So
yeah, I remember I think it's 3rd year, and there's a lot of pathophysiology, so learning like about rheumatoid arthritis and all the cells and the pathophysiology. And you're like, I just do not need to know this. I don't need to know about rheumatoid arthritis at this level. You really don't. So, but I think that's where it went. In my majority of cases, you're seeing soft tissue injuries, but they're so worried about allowing you to have the base understanding of pathophysiology and symptoms, which is great, so you can diagnose someone, so then you could refer. The biggest thing is, like, we want to make you safe, so if something comes in which is outside of your remit, you need to refer this is not what we deal with. But then the majority of stuff that you do actually deal with, you're not taught. That's the issue. So I do understand it's like probably a hard balance to find, because you taught all the systems exams. So you would do like cranial nerves, and you would like take someone's blood pressure, and you taught all that sort of stuff, like be able to do a GI exam. So you are, you're doing stuff what, doctors are doing. So you can say, I've done this GI exam and I think it's this. I need to refer you. And you do get a lot of people come in to osteopaths, believe it or not. You think you should just go and see your GP. Like, you don't need to come see me. So there's a lot to learn. So yeah, it's hard.
Just remind me of a funny story. Quick aside, but I'd met a bunch of Indonesian people here at a family event, and they couldn't speak great English, but one of them could, and was asking me what I did. And then he said, "Oh, you should speak to this guy." And he was saying, "Oh, you tell him what's wrong with you." And they're trying to say something like about the arse, and it's like, is it glute pain? You're getting like a hip pinch? What is it? What's going on? And they're trying to find the word, but they couldn't. And then we got Google Translate out, and he turned it around, and he's hemorrhoids. I can't help you with that. So
Yeah.
I think you need to see a doctor, not a biomechanics specialist.
Yeah.
But yeah, I think that's funny. With all people who do some form of treatment, they probably get inquiries a bit out of scope.
Yeah, 100%. So yeah, I think it's not. I can imagine it's not easy to design the curriculum, for sure, especially when it's trying to be recognised and they're trying to push it forward to more legitimate way of treating, more towards physiotherapy, really. But it's definitely not that effective.
So what is effective?
It's a good question. Functional anatomy, that's what I'd say is effective, because you learn anatomy from a book, and the way you assess is very segmentalized. But functional anatomy, understanding biomechanics of how someone moves and what the hip's doing in the loading phase of gait, lunge, squat, deadlift, etc., jumping, you start to see those patterns, and you can start to assess someone functionally, like, oh, that's missing, give a corrective or an exercise to restore that missing movement quality. Like, that's effective, especially for injuries which are musculoskeletal. So that's what I'd say is effective. Yeah.
Beautiful. And for people that haven't heard that term before, can we break down functional anatomy a little bit in more simple terms? Like, what does that mean? You touched on loading mechanics of the hip in gait or squatting or lunging. How would you explain that to a 6-year-old? What functional anatomy is? What are you looking at? What are you looking for? What are you doing about it?
Yeah. So what you're looking for is assessing how someone moves, essentially.
Yeah.
And understanding the parts which go into movement. What was your next question?
And then what do you do about it?
And understanding then, this is how you're moving. This is what you could say more optimal loading mechanic is, and then giving a prescriptive based exercise from that. So they teach their nervous system how to move via an exercise, versus the traditional approach is, oh, you're missing internal rotation of the hip. I'm going to manually internally rotate your hip. But then that has very low carryover, as you can imagine. Well, maybe not, because when you lay down is very different to when you stood up, which sounds very obvious. But you can mobilize someone's hip. Someone actually might have great internal rotation laid down, but they can't actually access it when they're stood up. So understanding where the person's at and giving them an exercise for where they're at right there.
Awesome. So take us through the evolution of your practice. You said as soon as you started practicing, you're already incorporating movement mechanics. And when you started out, what sort of blend of osteopathy versus movement mechanics versus training? Because you're a CrossFit coach as well, do some personal training.
Mhm.
So how did your practice evolve over time?
Yeah. So when I left university, I was working for myself a little bit and then working in a clinic for someone else as an osteopath. And I was treating more traditionally in the private practice of someone else, because the way they write the notes, their assessment, it's all like you need to say that they've come in with this, you've done these tests. So it's very like, so they can, look back if there was a complaint or someone tried to sue them, etc. So I treated very traditionally at the start, but because I was doing that, I didn't enjoy it and it didn't last long. And the types of people I was treating wasn't the people I wanted to treat. And they were usually maybe 50 to 60-year-olds with arthritic joints. So knee arthritis and it's very gentle mobilizations really, which made them feel better.
Yeah. So what happened next?
So then what I was doing on the side was blending a lot of soft tissue. I ended up doing a lot of soft tissue and biomechanics stuff. That was kind of like, because didn't like the reliance on HVTs, and because I was not doing them, then I was also not training the skill of doing them, because it is to do them effectively and fast with both hands in different directions and different setups. Like, you do need constant practice, especially when you've just left university. And because I didn't really see the effectiveness of them, as I was more into like, no, I want to try and get this person to move. If they're coming to me with lower back pain, I don't want to crack the lower back. I want to address why is actually the lower back is manifesting pain. So I would do like a little mini movement assessment. So some of the stuff I've learned from you, so I might just do like the posterior hip stuff, and then like do a bit of a treatment mobilization on the bed and soft tissue, because people were still coming at that point, coming to see me to get hands on. They wanted to leave feeling like they've been worked on, they've had a session. And I wanted to give them that feeling as well, because I know what it's like when you think you're going to see someone and you don't get the session you want. It's very unsatisfying. And then it slowly bled more and more to doing actually like pretty much soft tissue. So it wasn't really doing osteopathy. So it was just like a glorified sports masseuse. And then I was doing like biomechanics assessments on the side. And I separated them then. And then it got to the point where I was getting better at doing the movement mechanics assessments, which you taught me. I was being more effective with those, getting better results, and I slowly just started putting my price up and realizing they're more effective. And then the next step was then someone would come to inquire about having a like sports massage for their lower back. And then I'd ask them like, how long has it been going on for? And then realizing it's chronic, like what types of treatments you had before, something very similar. And it's like, I actually think this is a better option for you. So then I would like start to like sell them into doing more movement-based approaches. And then that was becoming more and more successful. And then it got to the point where only recently, and I would still do the odd soft tissue for someone even now, for like legacy clients, or if I just like them really.
You want to touch them? That's what you're saying.
That has been known. And and then so then now if someone comes to see me for like an osteo-based traditional assessment for the past 6 months of the year, I've just referred them to friends locally and just say like, if this is what you want, then go see this person, because I no longer do that.
And how does that feel?
Like $1 million. Yeah, it feels good. Yeah, because you work with we spoke about this, but you work with a better type of client. You work with someone who's willing to invest 6 weeks, 12 weeks, 6 months, a year into getting out of pain and moving better and getting back to what they actually want to do. You attract a client who is autonomous. Yeah, the main word is autonomous. They're willing to do the work and they don't need hand-holding, they need guiding. And what happens from that is they get way better results, and you have a more enjoyable work. Yeah.
Yeah, I think you touched on some of the big differences as I see them in terms of the functional anatomy approach compared to the manual therapy approach. And for me, one of the biggest pieces is that the client or patient has to fix themselves. You can assess them, you can find what's going on, you can find the root cause of the issue, but it doesn't work unless they do. And I think a lot of people go into the traditional manual therapies looking to get fixed, whereas the reality is, to solve a chronic issue, if you've got a dysfunctional movement pattern, you're going to need to do the reps to train it out of the body and re-educate the nervous system. So when people are conditioned to see these manual therapists and expect them to do the hard work, and they just lie there and get a rub down, it doesn't set them up for the success or the result that they actually want. And I think you've obviously seen it firsthand, the difference in results when you can teach somebody to move better versus them coming in hoping you'll solve all their problems for them. And I think it's a much more reward. What's the saying, like, teach a man to fish instead of give him a fish?
Teach a man to fish and he'll be able to feed himself for a lifetime. Give a man a fish and he'll be able to eat once.
That's it. And I think that's better for everybody at the end of the day. So that's so awesome to hear, mate.
I've had a recent client who's, I think it's very empowering for the client patient, because they realize that I don't need to touch them for them to feel better and get better. They can take themselves through it. They just need guidance. And I had a guy with probably the worst low back pain case I've ever had. He was seeing a chiropractor like 15 years, and he got to a point where he could barely walk when he first saw me, and we all he could do is breath work because he was at the start. And then now he's pretty much doing a full program 3 days a week, looking to get him in the gym soon, but it's just a lot of bodyweight based stuff. And he's now trying for a baby because he feels like he's capable of actually holding a baby. And he's, I don't know if it's too soon, but his wife's pregnant as well now. So like his life's like turned around. And this is a bit of a tangent, but he had an MRI, it finally came back, and then the surgeon was like, you need surgery. And the image does look pretty messed up, but he's like, well, I don't have pain anymore. So he was very confused. And that's the thing about MRIs, for people who don't know, is that you can have no structural damage and lots of pain, and lots of structural damage and no pain. So it's hard. You can't just look at an image, and that's the downfall of this surgeon. He just saw this and not actually had a good conversation with him and understand where he's at. And what he's actually done is given the guy a lot of anxiety and not understanding what's the next steps actually best for him. So it's really effective.
Awesome. And I guess to summarize things, if you could do it all again, if you were just starting down this journey of being a practitioner helping people with injuries, what would you do differently, or how would you change the system to help people? Because I think everyone who works in these sorts of jobs has great intentions. They want to help people, and that's generally the type of person who gets into a healthcare or sort of treatment-based profession. But unfortunately, the tools they're given don't necessarily let them do the things that they want to do for people. So knowing what you know now, what would you like to have been available for Lewis just starting the education pathway towards doing?
I think that's a good way to put it, because I wouldn't really change anything, because as you know, it's like if I change anything, then I wouldn't have taken this path. But what should have been available is the functional anatomy, the movement mechanics, the biomechanics side, because we only had 1 hour in 4 years on exercise and stretching. Well, like exercise prescription, which is just pretty much stretching in 4 years.
That's mental. That's like doctors having half a day of nutrition
It's that
advice
same.
in 7 years.
But I think it's more disproportionate, because that's actually who we like. They don't deal with. Well, they do deal with people who are having nutritional issues, I suppose, but that's realistically the bread and butter.
Pun intended.
Yeah. So it's absolutely outrageous. So I always say that I wish that your course was the part of a university degree. That I feel like it's massively missing. I don't see it happening anytime soon, unfortunately.
Yeah, it is sad, frustrating. I think movement is the fundamental currency of the human body. Like the human body is essentially evolved to move in some way, shape or form. All of it, like the brain included. And if you're dealing with physiological issues, movement has to be considered. Even when it comes down to things like detoxing, you need to move the body to stimulate the lymphatic system to clear toxins. And movement is a part of pretty much all that stuff. So I find it crazy that even in personal training qualifications, it's so underrepresented in terms of how a body moves functionally.
Yeah.
So I agree with you.
With osteopathy, they do like lymphatic drainage techniques. They understand the system, but you'll be physically doing it to someone like they're bedbound and they can't move. But well, all the lymph is around the major joints. You need to move the major joints for the lymph to pump. So you would do like these like techniques where you'd be like pushing someone's feet, then like twisting someone's calf and knit, and then you'd be like mobilizing someone's hip. Then you would do like I forgot their name now, but the duct, where you'd like press on the chest, you would like mobilize it, do the spleen with the ribs on the side. You'd go through this whole little system to move the lymph. But it's like, if that person's doing 1,000 steps a day because they're a desk worker, you'd be way better off just telling them to like walk for 5,000 steps a day, and you'd move way more lymph, and the like fluid would go down less in their legs. It's
and there's tons of other ancillary benefits as well. At
yeah,
the same time.
Exactly. So it's there's simple prescriptions, but that zooming out and looking at things more holistically, and that's what osteopathy prides itself on. And I think I love the premise of it all, but it just wasn't taught.
Yeah. So what would you say are the key takeaways? Like if I say to you, is osteopathy a waste of time? Obviously that's a bit clickbaity, but how would you respond to that?
I would say it's not a waste of time, because you are forced to learn a lot, even though a lot of it's not that effective, but it allows you to, like you said before, people are in there are wanting to help people, so that everyone's in the right mindset. And I think it allows you to be in that environment. I think but I don't know, actually. The way I look at it, and I suppose we spoke about it before, is being an osteopath, you see people in pain. People are coming to see you because they're injured or they're in pain. And that means that you have a steady flow of people which you can practice on. And if you didn't have the title or, the legitimacy of that, a lot of people would struggle to have that, potentially lead generation of people, to work with people who are in pain. So I don't think it's a waste of time, because you do get to work with the people you want to work with. The system and the techniques they give you to work with those people aren't effective, and you need to learn the other techniques and systems which are effective to treat those people. But the main point is that you are seeing people, and people are coming to see you. So it's like, that's the first step. So it's not a waste of time, because that's the first step. I know you've gone a different way about it, much more difficult way about it, I would say. But I think that's, you've become a better practitioner for it as well, though.
Yeah, and I think it's so hard to sum up a whole industry practice in even one podcast, but there are so many positives, and like you said, the techniques aren't necessarily optimal or the best ones. There's going to be some good stuff in there, but you did come out of it with a great understanding of anatomy and physiology.
Yeah.
Your knowledge of muscle origin and insertion points was as good as it gets, really, which lays phenomenal foundations for learning other approaches.
Yeah.
So I definitely wouldn't regret it at all if you've already learned that stuff.
No.
But I think it's just potentially indirect way of getting from A to B. But like every educational journey, nothing's ever useless, because there's going to be even attitudes and thought processes that maybe relate to completely different topics. Just your train of thought or your logic for doing the detective work in an assessment. You can control variables and do some different testing and spin things off in a different way. But yeah, when you say it like that, when the techniques don't work, are not effective, then yeah, that's pretty damning, isn't it?
Yeah. Maybe caveat. Acute cases, like 0 to 6 weeks, I think those techniques can be effective as long as the person has the ability to recover and they're not super stressed and all that sort of stuff. And it's not too complex. Outside of that, it's pretty redundant. And you've had people, seeing physios, chiros, osteos for years, and, and they love them. Like, my chiropractor's amazing. He's seen him for 10 years. It's like, no, he's not. Because he would have fixed you a long time ago.
Yeah.
Or referred you to someone who could. And I think that's a big thing for me is, I've worked with a lot of people who have been seeing people for years, and these practitioners are so desperate to keep them as clients, realistically, because they don't refer, and they're not, and they're trying the same old thing. And it's like, when, I think morally and ethically, it's like, just like, allow your ego to just come down a little bit and just think, I don't know what's going on with this person. And I have, I've had people with that, sometimes recently too. And it's like, well, maybe you need to look elsewhere, because I've tried everything I know and it hasn't worked, unfortunately. So maybe see this guy or this girl.
Yeah. I think that's it. Something I talk about quite often is the incentives are just at odds sometimes. If you're only getting paid when someone's in pain, then why would you want to get them out of pain? Whereas the hybrid clinician, as I'm calling it now, we're seeing a new wave of practitioner who can treat but can also train. So they're incentivized to get somebody healthy, because they become a better customer by being healthier, by being pain-free and working towards their fitness goals, rather than just only seeing them or only getting paid when they're hurt and need rehab. And I think in that way, the incentives are so much more aligned, because the patient obviously wants to be fit and back to sport and training, and the clinician or hybrid clinician also wants them to be back to training and moving towards their fitness goals. And I think that's a huge trend that I'm seeing, that I'm really pleased to be seeing, because the old school, he's been my chiropractor for 30 years, and a lot of chiropractors are sick of that as well. Like, a lot of the guys on the mentorship are saying that themselves. So
and same with my friends, within the same year as me, they're all looking to, one has started the mentorship, others are looking to start it because they're not fulfilled by the work. I think it's really common. In fact, they're working with people they don't want to work with. They're not really getting the results, and they're starting to look elsewhere. But not the dangerous thing, but I suppose it is dangerous and a bit sad that some people just don't ever do any real CPD, and they're not really reflecting, and they will, from university until maybe until they retire, they don't change their practice a whole lot, but they get busy because they've been doing it a long enough time, word of mouth, blah blah. But
I think that's why I'm grateful that yeah, people like you, there's so many people on the mentorship now who are very self-aware and self-reflective that they can take a step back enough to look at, like, hang on a minute, I'm doing everything I was taught by the book and the results aren't coming. Or I'm looking at these guys who've been in the game for 20 years and they don't seem to be getting amazing results. If they were doing the right things and gaining experience and getting incrementally better, surely they should be getting phenomenal results, but they're not. And it's almost like a step out of the matrix. You know, if when you're in uni and you're surrounded by people all singing off the same hymn sheet, like, are we allowed to question whether this is actually a logical way of approaching things? And I think, yeah, there's many, many people now reflecting on things and thinking, maybe this, just because it's what's taught in school, maybe it's not the best way to deal with these sorts of issues.
Yeah.
And it's great to see, to be honest.
I think if you're a student or a therapist listening, you've probably had this feeling where someone asks you a question about what's going on and you actually don't know because your level of understanding isn't deep enough. And for me, that was incredibly embarrassing. And I would probably come up with some bullshit answer. And that's why so many like physios like, it's your posture. Or why have you got back pain? Oh, it's because you got a desk job. It's like, oh, it's because of your shoes. It's like you're standing wrong. It's like, fuck off. It's just ridiculous. But when people ask you, I was just embarrassed. And I was like, I need to know more because I don't know enough. They're asking me questions I don't know. And if someone asks me that now, I actually say, I don't know, because I'm comfortable with the level of understanding I've got. And I know I need to learn more. But if I don't know something, it's like, fair. But then it's because I genuinely felt like an imposter, because you are really.
Yeah. And I think in those situations, the truth of the matter is that it's impossible to say, like, you're at the pub and someone says, oh, my back hurts when I run. What do you think it is? Like, it's impossible to know. Like, based on what you told me, that tiny amount of information, there could be a number of things going on that are leading to your back pain. And what you want is me to give you a 5 to 10 second response which solves all your answers, all your problems, and that's not how it works. And I think once you've seen it enough times, or you've seen enough bodies, and you know how things work, like you say, you're comfortable with that answer, and it's more aligned and authentic to say, I can't tell you. I could probably work it out if we had an hour or two together.
Yeah.
But yeah, it's not the sort of thing that you can give a quick answer at the pub about.
Yeah.
And people don't necessarily like hearing that as much as someone with high conviction saying it's definitely this, definitely change your shoes.
Yeah.
But yeah, I think that's a better place to be.
Yeah, 100%. I think it's probably one of the worst things about nights out and knowing that someone knows what you deal with people in pain, because they'll hang off the back of you.
And on that note, I think it's a great place to leave it. Thank you very much, Lewis, and I'm sure we'll be hearing from you again soon.
Cheers, mate.
I hope you enjoyed that episode, guys, and gave you some food for thought. It's certainly something I've thought about for many years, the limitations and drawbacks of traditional treatment and therapy for injuries. And if you would like to learn more about movement mechanics, please check out thetrainingstimulus.com. We have a ton of free educational resources on there. We have a school community you can join up to with several masterclasses. We have an exercise of the week library where we deep dive on specific movement mechanics exercises, some of our famous silly lunges, and biomechanical breakdowns in case studies as well. So that will give you a good sense of the world of movement mechanics and hopefully give you plenty of useful takeaways as well. So check that out, guys, at thetrainingstimulus.com, which we linked in the show notes below. But hope you enjoyed that one as much as I did, and we'll see you next week.